this is a case of post-RK, and let us count the number of cuts. 1, 2, 3, 4, 5, 6, 7, 8. So, when you have 6 to 8 cuts, you can have a limbal approach. The only thing here is to identify which should be your entry area. You should have at least 0.75 to 1 millimeter on either side of your keratome. So, I will rotate my microscope to have the widest area of entry. You can notice that I am aligning my position according to the port. So, this area for me to enter. Always have a little limbal entry in these cases. I will find the area in between and have slightly longer tunnel, and then you will notice we have nearly 0.75 millimeter of tissue space on either side. Viscoelastic. Few things to take care when planning such a case is you should incorporate new formulas, inform the patient of instability of refraction for first couple of weeks, and also plan your IOL to be toric only if the patient was improving with toric glasses or astigmatism was regular and the refraction has been cylindrical refraction has been stable over a reasonable time. Another thing to incorporate is make sure you use the Barrett-Truquet or any modified formula which is recommended for post-RK patients. The flattening in RK is totally and universal across the cornea, unlike LASIK, where LASIK the flattening is only in the anterior chamber. Now, we will have to make sure there are no sudden increase or decrease of anterior chamber depth. Now, light में देखेंगे मैम. Okay. Now, this surgery is under topical, but if there were 12 cuts or more, I would have usually gone in for the case under block and gone in for a scleral approach. My regular bottle height is 110, but here I will go for approximately 105 to 100 millimeter mercury. If you notice, I made a slightly larger side port, and I'll keep my side port dipped so as to cause enough leak so that there is no build-up of pressure.
सर नीचे से बॉटल मेरे कान में जा रहा है.
मैं वो ख़त्म हो जा रहा है. सर्जरी तो आपका 50% हो गया. So, we have got a chop. So, when I don't want the pressure to build up, I just dip my side port and cause some leak so that the IOP doesn't build up to cause stretching of the cuts, because as we all are aware, in patients who have post-RK, the corneal cuts have a unique ability to distend and open up. So, also most of the movements in the main wound are linear, forward and backwards. We should avoid these lateral movements because they can also cause stretching of the corneal cuts. So, 2-3 things to remember: stable anterior chamber, least amount of movements in the main wound, dipping of the side port off and on whenever you feel that the IOP is going up. You might see some chamber fluctuations because the reason for that is a lower bottle height. And there you are, the case is over. मैम सर्जरी आपका ख़त्म हो गया है. ठीक है, बस अभी हम लेंस डालने की खुद तैयारी कर रहे हैं. आपका लाइव ट्रांसमिशन भी हो रहा है साथ में. लाइट को देखिएगा. Again, dipping the side port, making sure the chamber is not over pressurized. There is also some slight leak of fluid from the main wound, which is also to my advantage. So, increased intraocular pressure is the sole culprit when these corneal incisions will open up, and you will notice how beautifully we've been able to maintain the corneal incisions, no distortions. it's always a good idea to plan your toric lens in case of a post-RK patients only if the posterior float and the total corneal power is also available to you. Otherwise, sometimes we can land up with a cross astigmatism or a compound astigmatism. So we polish the posterior capsule and there we are. लाइट को देखेंगे मैम, हिलाना नहीं मैम, बिल्कुल नहीं हिलाना आपने,
बताइए कहाँ देखूं सर?
बस लाइट में देखिएगा मैम.
सामने ना, सीधा ऊपर.
यस यस, बहुत बढ़िया हो गया आपका.
ओके सर.
ऑयल कौन सा? So my choice of lens in such cases is an IOL with rigid haptics, which tends to get locked in the bag. Most of the patients will have very deep anterior chambers in such situations because of previous high myopia. And we can see the lens is centering beautifully. Surgery is over. Light को देखेंगे मैम. These patients also tend to have a lot of surface disorders. It's always a good idea to do their dry eye mapping and estimate the right keratometry before we plan the toric lens because of the corneal incisions. So treating the surface disorder, especially if you are planning a toric lens, luckily this eye did not have much astigmatism, so we have not planned a toric IOL in this eye, but the other eye in the patient has got a toric lens, so we will be planning a toric IOL in the second eye. And there you are. Now the final caveat here is, normally when you hydrate your wound, light को देखेंगे मैम, you should be very gentle. मैम थोड़ा chin उठा लीजिए ऊपर मैम please. So you should hydrate your wound very gently, no overhydration because it can spread over. And always a good idea to hydrate the roof of the wound rather than the sides in a post-RK case, because you can cause an unnecessary hydration of the incision and cause extension of the incision. And there you are. Beautifully centered lens, absolutely perfect surgery. Thank you.
थैंक यू सर. हरे कृष्णा सर.
हरे कृष्ण. लाइव ट्रांसमिशन हो गया आपका ऑल ओवर वर्ल्ड सर्जरी का. निकाल लो. बताइए, पता लगने दिया मैंने आपको? आप ऐसे भी आपको से